Hey guys, so this week on the NatRevMD Podcast, we are going to talk about the question we talked about a couple weeks ago around dropping insurance, but today we're going to really focus on Medicare and just kind of some of the nuances around dropping and opting out specifically of Medicare. So as you guys know, I'm Dr. Heather Signorelli, and this is the NatRevMD Podcast where we help practices take control of your revenue. We are a full service medical billing and coding team based out of South Carolina, and we help hundreds of physicians at this point managing their billing and really help practices with the operation. So if you know somebody who's looking for billing services, have them head on over to our website, natrevmd.com, natrevmd.com, and check us out. All right, let's get to the topic. So I get it. Medicare is frustrating. They continue to lower reimbursement rates. Depending on the size of your practice, there may be some compliance headaches or MIPS that you have to comply with. And so you may be thinking, okay, I can think about, moving to direct pay or dropping this payer. So we're going to talk about opting out, how it differs from being a non-participating physician, why we see some practices considering it, why some practices have moved that way and regretted it, and kind of what the data shows around different subspecialties. I will say personally, we have, as a billing team, have really liked Medicare. And the reason for that is it's really crystal clear what they're going to pay, why they're going to pay it, what's covered by diagnostic codes for each CPT. They pay within 2 weeks. I would say in general, like Medicare is very easy to work with. Granted, I know it's frustrating with rates and depending on what they do, but really I find Medicare to be very easy to work with in that regard, but I get it. And so wanted to bring this to you guys again, just how to think about it. And then you can kind of make those decisions and go from there. All right. So what does it mean to opt out of Medicare? So opting out basically means that you're completely outside of the Medicare system. You cannot bill Medicare for any services. Patients cannot submit claims to Medicare either. Instead, really every Medicare patient you see must basically sign a contract agreeing to pay you out of pocket and agreeing to certain fee schedules and recognizing that you are out of network. Now, in those circumstances, you're free to set your own rates, but you are also completely responsible for kind of managing those patient responsibilities. Now, I will say that is like I've opted out. I'm completely opted out. I'm not part of Medicare at all. The difference is to be non-participating. So a non-par physician, you're still enrolled in Medicare, but then you get to choose whether or not you're going to accept kind of an assignment or a patient for a specific service. And in that circumstance, you're typically paid 95% of Medicare rates. Now, if you say, oh, I'm not going to accept and bill that to Medicare, instead, I'm going to charge the patient a cash fee rate and the patient can bill it to Medicare and get reimbursed directly, you can actually set a fee schedule up to 115% of Medicare allowable. And the patients obviously then submit the claims and they seek partial reimbursement. So difference here is non-par, right? You're still in Medicare, you have some pricing flexibility, but you still have some compliance stuff to deal with. And then completely opting out, which means you're like patients can't submit claims. You're not going to get paid for Medicare. They're not going to get reimbursed for Medicare. But you can, choose to charge whatever you want. So kind of two different ways to do that. Now, I would say in general, when kind of doing some research for this podcast, I wanted to look up some rates of like how often are people really opting out of Medicare. And I would say from what I found, it's very little. It's less than 1% to 2% of physicians are opted out of Medicare. And really that's mainly just because of the complexities around dropping Medicare and losing those patients. So when you think about psychiatry, actually had the highest opt-out rate, and that was at about 8%. Plastic surgery, neurology also had a higher rate than average. Makes sense, right? Psychiatry typically has a different relationship, longer patient visits and so forth. Plastic surgery is oftentimes cosmetic. Neurology, I think I had to think about this one for a second, but to me, my personal opinion, and again, they didn't kind of note this in the article, but neurology is just really hard to get into these days. So maybe they can charge cash pay just because there's so few of them and people are willing to pay to get in. But a lot of other subspecialties, internal med, family med, oncology, et cetera, really remain even under that 1% opt-out rate. And most states are kind of under that 2% opt-out rate, with slightly higher rates in DC, Alaska, Colorado, and Idaho, oddly enough, which is strange. I lived in Colorado for almost 20 years. So found that interesting. But let's think about some kind of other things for you to consider. So when you opt out, you do have to file an opt-out affidavit to the Medicare, administrative contract, or MAC. And that opt-out period lasts a minimum of 2 years. Now, there is a waiting period of 90 days, but basically, like when you do opt out and that waiting period is over, you can't get back into Medicare until that 2-year period is over. So you can't change your mind a year into it. And that opt-out will automatically renew unless you cancel it. So you do have to think about that. Now, if you do again, change your mind, you can't re-enroll until that 2-year window is up. So you just really, really want to make sure that this is something that you want to do. And so the next part of kind of what we're talking about is really going over why you would consider dropping Medicare and, kind of how to think about this from a business perspective. And again, I did a podcast a couple episodes ago, I think it was 107, where we talk about dropping commercial payers and how to think about it. This is a very similar conversation as to that, but important for you just to wrap your head around, okay, what metrics do I need to pull? How do I think about this from a business perspective? Because the last thing you want to do is not be able to pay rent or employees that you need to keep. So obviously, a lot of reasons we see people wanting to doing this is just reimbursement rates compared to commercial payers, although we see some commercial payers paying even lower than Medicare. So I think it just depends on your subspecialty, your payer rates, how big are you, and can you really get away with this from a patient perspective, right? So will your patient stay? Will you get enough cash pay patients? Will you get enough replacement with commercial payers? And really just want to make sure that you really, really understand that before you make any decisions. Obviously, if a large portion of your patients are Medicare and you do kind of a subspecialty like cardiology or GI, you may struggle with having enough patients that retain and want to stay, especially if the majority of their coverage is paid for, right? It's an added expense, and not everybody will be able to pay for that or choose to pay for that. Another thing to remember is that hospital privileges. So a lot of hospitals still require you to be enrolled with Medicare for credentialing and call service at those facilities. So you're going to really want to make sure you understand how being out of network or opting out impacts them. And so if you are seeing patients in a hospital, really important for you to understand that. Also know that you're going to want to keep contracts that you have patients sign for 6 years. And obviously, of course, accidentally billing Medicare or opting out is certainly something you're not going to want to do. So if that does happen, you're going to want to make sure that you get that claim pulled back. Another thing to consider is Medicare Advantage plans. So these are separate commercial contracts, and in some cases, you can stay active in those Medicare Advantage networks, even if you've opted out of traditional Medicare, and sometimes you cannot. So it's going to be dependent on that payer. So you're going to want to make sure you understand those rules around Medicare Advantage, and then making sure if you are deciding to opt out of Medicare Advantage as well, that you let them know as well. The other thing to recognize is just some complexities around secondary payers. So if you have a patient who has Medicare as a primary and commercial payers as a secondary, that you understand how opting out of Medicare is going to impact those secondary payers and how you can continue to get paid from the commercial payer side. So just some nuances around all of that you're really going to want to investigate before you make those decisions. All right, so the things to think about when you're trying to make this decision around, am I going to drop Medicare, is really going to be about the numbers, right? And I talk about metrics and managing metrics a lot, right? From a billing perspective, you should be tracking and trending those things all the time, denials, so forth. So you're going to want to run the numbers, right? You're going to want to run the numbers around percentage of your patients who are Medicare, both from a percentage standpoint as well as a raw number perspective. So if 50% of your patients are Medicare, that equates to 1,000 patients a month. You're going to want to know, okay, then what is that revenue? So what is Medicare paying you, not charges, but paying you for that, percentage of your patients? And then if you lost all of that revenue, right, worst case scenario, how does that impact your expenses? How does that impact, the staffing, et cetera? And what would you do with that complete loss of revenue? And then what's your plan to make up those numbers, right? So say you can estimate, maybe you run different models where you estimate, okay, 20% of my patients stay and pay cash, or 20% of those patients I can replace because I've got a long commercial wait list. Then those are the things you can think about in order to decide, okay, worst case, best case scenario, somewhere in the middle in terms of loss of revenue. And could I sustain that? Could I pay my bills? And how likely is it that your patients are going to stay direct pay? You're obviously going to want to have things in place in order to manage this, right? Communication plans around dropping Medicare, communication plans about converting those people to cash pay practices, cash pay slots, communicating to your commercial plans that appointments have opened up and how to get them booked and filled. Because the last thing you want to do is drop a payer, any payer, and then have a whole bunch of slots open that you can't, that you're losing money, right, by not having them filled. And so you really want to have a plan in place around dropping these payers, how you're going to get patients in the door, how you're going to flip the patients to cash pay. I mean, all of these things are going to be really, really important for you to think through. And then how are you going to train your staff, right? Your front desk, your billing teams to be prepared for the questions, managing kind of the different billing workflows, et cetera. So really, really important for you to have a plan in place if you are thinking to do this after you've looked at those metrics, after you've kind of run the worst case, best case scenarios, and then how you're going to operationalize this on the back end so that you can explain it to patients, communicate, set a date, train your staff, and then find the other revenue parts to help make up that loss in revenue, and come up with a time frame of how long you think that loss in revenue is going to potentially last. So very important for you to also think through referral partners, right? So, and this is a two-way referral situation, right? So how are you going to handle patients who can't afford to stay cash pay? Who are you going to send them to? And then on the flip side, how are you going to work with other practices that are referring you patients to see how you can get, those spots filled with other commercial or cash pay patients? So just, business decisions, right? Business is not easy. I don't think any of us thought it was going to be easy. I think if we wanted it to be easy, we would have picked a different route. But it's also really fun. You get to decide kind of how you run your business, who you see, what you want to be your headache, right? I think we're all going to have headaches in business, but it's just what headache do you want this week? So really important for you to kind of think through these things and really think through, what is your short-term plan for practice? What are your revenue goals? What are your profit goals? And then what is the business model that you want to be in? And then it's about choosing that revenue model. So if it is full insurance based, how are you going to optimize that? If it is a hybrid model, how are you going to optimize that? If it is dropping certain payers, how are you going to optimize that, right? And so you really want a process by which you are thinking through those things. We've also, been chatting with different folks who are doing kind of this hybrid model where they're bringing in membership models. And I know I've done a past podcast on this in the past, but we're actually going to have a guest speaker come on in a couple weeks who's going to talk to us about, how to think about that and develop that out more to where you can still be insurance-based, but then build on some of these membership models and be successful with it. So of course, medical billing, running a practice, being a healthcare physician is tough. It can be, challenging, but so can any business. So can a marketing business. So can a consulting business. Heck, so can an HVAC business, right? I mean, business is not easy. I think it's a matter of finding the things you really enjoy doing, identifying the problems you're having, and then people who can help you solve those problems. So as always, if you are enjoying these podcasts, share them with a friend. We'd love to be able to educate and share kind of our experience with other physicians and healthcare practices. So leave us a review on wherever you're listening to us and share as always. So if you are looking for some help kind of answering some of these questions, reach out to us at info@natrevmd.com. Thanks so much for listening. We'll talk to you soon.